These kids absolutely need an IV.
You can give them IO, right?
You can, yes, yeah. I consider IO as IV because most things you can give IV, IO, yes. So these are definitely the immediate ones, and before you arrive, they should be taken care of, or if you arrive, you can do very quickly. And we do most of these on our own, and they are quite obvious. The neurologic exam is going to be very difficult to do because most of the time these kids are seizing, and that's going to be your neurologic exam. And so from here up, I get very comfortable with, because we'll talk about the treatment algorithm afterwards as far as what drugs you ought to be giving.
It's very stupid, but AED is meaning
Anti-epileptic drugs. Yeah, sorry. Yeah, no, that's a good question. Yeah, anti-epileptic drugs, yeah.
Oh.
Because usually it means something else.
Do not shock.
So this is something that probably should be on your notebooks that our RTs right now have in the bag. We talked a little bit about it. This is your booklet, and so if you have any recommendations, I don't know which one of our coordinators wants to champion it or one of you guys, but this is your booklet, and if you find that there should be things in the booklet, then we ought to put it in there. And so this is a really nice thing. This is the algorithm that we did in Chicago, and it's very straightforward. Treating seizures is like treating sepsis. It's all protocolized. So again, you come and see the patient, ABCs, that's obvious. Most of the time, if they haven't been absolutely schwacked with anti-epileptics, A, B's, and C's should be intact. Okay? Access, absolutely. Bedside glucose, absolutely. And that's really the first box. Exactly what we do with all of the patients that we see. So now if the kid is seizing for 5 minutes or so, what is our first options? Well, if we have IV, it can either be lorazepam or midazolam at 0.1 per kilo. And basically it's a quick bolus dose. We have diazepam per rectum if you can't get IV access, but in my preference, if we can't get IV access, we go IO because we're going to be on transport. There's only a certain amount of drugs that you can stick up the bum, right? So lorazepam or midazolam is our first round. So then we see if the seizure continues. If it doesn't continue, sorry, 1 second. I'm sorry. If we're dealing with a neonate or less than 1 month of age, phenobarbital is a really nice drug at 20 per kilo. One of the advantages of phenobarbital is it seems to work good for the younger kids, where dilantin seems to work a little bit better for the older kids. The problem with phenobarb is that it can cause you to become apneic, it can drop pressures, and so use this with caution. So if we start loading with phenobarbital, again, we go back to our ABCs. You can go up to 40, so 2 20 per kilo loads of phenobarbital in the neonates, and that stops. We have phenytoin, we also have fosphenytoin. They're basically the same drugs, except fosphenytoin is a little bit nicer on your blood vessels. For older kids, we do dilantin. Phenytoin is the same as dilantin, 20 milligrams per kilo IV. If that doesn't work, then there's a possibility to give another or 20, just like we do with the neonates. But really, from this point on, you're going to be talking to medical control, right? You're going to give the lorazepam, you're going to give the midazolam on your own, and you're going to monitor. And as you're waiting, you're going to talk to medical control. So think phenobarb for young, dilantin for a little bit older, recognizing the dose is both 20 per kilo and recognizing as well that you can double that dose as well. There are some people that would say, we're going to try fosphenytoin dilantin, 20 per kilo, and if the kid stops or continues to seize, we're going to try phenobarbital. So there's a bunch of different cocktails that you can kind of use from this point on. Okay?
Are we carrying both dilantin?
We are carrying Ainsley in our bag. We have dilantin and we have midazolam. And we have phenobarbital, I'm quite sure. So we have all three of them. Yep. What you have to do though, this is why it's good to have in your bag. I would memorize your dose of lorazepam or midazolam, because this isn't time to have medical control online. If there's somebody seizing for more than 5 minutes, you have to be comfortable giving that drug.
Is Midaz same dose?
Exactly the same dose, yeah.
Is it in our flip cards?
Sorry?
With our recess drugs?
It is in the RT book, I believe, and if not, we can add this into your book.
Okay.
What are we talking about? This algorithm?
Well, and the dosage. Like, do we-
Well, okay, the dosage is in the medication chart.
Yeah, okay,
Yeah, but
okay. So
we can add this. Yeah,
we'll
this
have
can
it.
be added easily.
Yeah,
Yeah,
this would be
Yeah.
nice. Yeah.
This should be added.
Yeah.
we'll plasticize it, we'll laminate it.
So what happens then? The kids continues to seize. They've been given 40 per kilo phenobarbital. They've been given 30 per kilo of dilantin. What happens? Well, you guys are there. It's going to go to the ICU. You are the ICU. What are your options? Really, the option that you have on transport is giving them midazolam, more midazolam, and more midazolam. Those are your options. So really, your line will end up here. And I've given a nice little loading dose of midazolam here. And essentially what you do is after the loading dose, you start an infusion of midazolam and you keep on bumping it up until the seizures start, or stop, sorry. And so really this is the end of your line. If you come into the ICU and the kid continues to be seizing, then we're going to start dealing with other things. We'll start talking about propofol perhaps. We'll start talking about barbiturate therapy, valproic acid, etc., etc. But your line ends here. So really for you, it is midazolam or Ativan, 0.1 per kilo. And then for young babies, it's phenobarbital. For older kiddies, it's dilantin. If that doesn't work for older kids, you might want to throw a little bit of phenobarb. And if that doesn't work, midazolam and a whole bunch of midazolam. So it's very straightforward. Now, from the selected laboratory studies, a lot of the things you won't be able to do if you're nowhere Manitoba, but as we said, you can do a glucose, you can do an extended lights, and you'll likely be able to do, if the lab is there, a CBC diff, and really that's perhaps all you need. Most important thing is a very, very strong history, so that when the kid comes here, we can select certain labs that match the history that you got. Okay? So straightforward, and like sepsis here, I like this diagram here because sepsis protocol is time sensitive, move quick, move aggressive. First 5 minutes, you're going to see, is the kid going to stop or not? If not, benzos, midaz or Ativan. If they keep on seizing more, what are you going to do? Phenobarbital or dilantin. And if they keep on seizing, we're going to get them on the midaz drip. It's quick, because the last thing you want to do is wait and you got this refractory brain. Time is brain. I should have said that with TBI and HIE. Time is brain, time is brain, time is brain. And we have to act aggressively with these people. So, identify the seizing child. Very easy when they're shaking. A little bit more difficult if it's non-convulsive. Very easy if it's refractory. But sometimes, I think more for neonates, and sometimes it's tough to tell if the neonate is seizing or not. Sometimes it's really difficult. But if they are seizing, treat quickly and aggressively, and then because of your treatment, recognize what your treatment's going to do. It's going to cause likely an inability to protect the airway. It's also going to cause likely various elements of hypotension. Okay?
If we think like they're having sort of an abnormal type seizure, like polychromatic, that we brought down from the ward the other day, and we were like, are they seizing? Are they
Become experts on the chest X-ray. And again, please, anytime you're on service, bother the attendings that are there. I don't know how the NICU operates or where they view imaging, but if you're on the PICU, bother me, bother whoever's on, okay? And look over X-rays, Pediatric abdominal X-rays are something that I wouldn't expect you to get really comfortable with, because quite frankly, the amount of calls that you'll get for acute abdomens are not very big. And the ones that you go down, oftentimes what you're going to see on abdominal X-ray is absolutely nothing. For a really bad appy, for example, what you'll see on X-ray is absolutely nothing. It's different than the neonatal world, for example, right? When you have neck and you have free air in the portal vein and you can see pneumatosis and testinalis and things like that. By and large, what we're going to see on X-ray is nothing. But there are some things that you will see something.
I'll take it out.
And if you do see something, you are not surgeons, I am not surgeons, you can do nothing except support them, but we'll talk about that. So we'll review the abdominal X-ray in kids in not anywhere near the same detail we did with chest X-rays. We'll review some common GI emergencies and introduce some strategies. A fairly blanket talk to cover big areas. So pediatric x-rays, they're cheap as borscht, they're almost everywhere, they're portable, low radiation, all good. The problem is that they're not specific, they often don't answer the question that you're asking. They're very hard to interpret, as far as really what it boils down to is what are the question you're asking, and can you answer it or confirm it with the abdominal x-ray, and you'll see in most instances you cannot. So when is it indicated? Really there's few indications for an abdominal x-ray. If they swollen a foreign body, that helps because it will light up and you'll say there's a swollen body or a swallowed body, but that typically will present on x-ray. But you want to know where it is, so that's important. Is there a possibility of intestinal obstruction? Well, typically, yes, you need an abdominal x-ray, but you're going to get a very good idea on history that they haven't pooed. Their belly is big and it hurts. Possibility of a bowel perforation, possibly, but abdominal x-ray isn't the best in most instances, and placements of lines or tubes. So really the absolute indication to do it, there aren't many, and typically, did you swallow something that you shouldn't have, and is it possible that you're obstructed somewhere? Constipation, for example, is a clinical diagnosis. There's no need to do an x-ray. So one of the reasons why I want to go over the very simple abdominal anatomy is because you have to understand the layers when you're looking through it. You guys understand chest anatomy very well because we do that on a day-to-day basis, and really in the chest there's not a lot of things that are cooking there. But when you're looking at the abdomen, there are a lot of things. And one of the things that I want to draw your attention to is the fact that if you open up the abdomen, there's not everything is free flowing out there. It's not like all your guts are there and everything's going to come out, because there are a few parts of your bowel that are retroperitoneal, for example, that no matter how hard you reef on it are going to stay behind your abdominal cavity. And so, for example, my stomach, it drains into my proximal jejunum or duodenum, and then jejunum, and as it makes the C-suite, it goes retroperitoneal, and then it comes out again. And so that there are some parts of the abdomen that are in fact not in the abdominal cavity and are behind that. And so retroperitoneal here, the parts of the duodenum past that C-sweep, as I was saying. Surprisingly, your ascending your ascending colon is goes descending, ascending. Those parts of your colon are retroperitoneum. Your rectum are retroperitoneal as well, and of course all your kidneys. So why is that important? And we'll discuss that in a little bit of detail later, but not everything in the abdomen is in the abdomen. Some of it is retroperitoneal. So when you look at the body as far as your physical exam, and also a way to think about it, we typically, surgeons like to think about it in 4 quadrants. Right upper quadrant pain, right? These are typically your gallbladders, for example, right? Your right upper quadrant. Left upper quadrant, what is there? Well, your spleen is there, and this is your transverse colon here is about to go down. Right lower quadrant is where your appendix is, for example. Left lower quadrant, there's a lot of things that can happen there. Your rectum is there, your descending colon. So one way when you're looking at the x-ray is to orient your physiology based on quadrants. Then some people said, well, 4 quadrants isn't good enough. Why don't we go 9 quadrants? Epigastric area being your stomach right below your xiphoid process, but just another way to think about it. But get your anatomy organized a little bit here so that when you're looking at an x-ray, you kind of have a good idea about what should hang around in those quadrants. So as far as the organs are concerned here, your right upper, as we talked about, this is typically where your pancreatic pain and your biliary tract pain comes from your liver. Part of your colon here, right at the flexure point. Here you have your spleen, largely your stomach, a large part of your colon. Your appendix, for example, most of your bowels are in your lower quadrants. So when we look at our solid organs, again, just reinforcing this over and over again, where all our organs are. And so I want you to have that in mind before we look at X-ray. So as we talked about with X-rays in kids, chest X-rays, we have a very, very organized way of doing about it. We look at ID, we look at quality, we do the outside-in approach. There's a number of mnemonics. The IT-free abdo is one that you don't forget so that you make certain that you get everything on it. So the I part of the IT or the IT-free abdomen or abdo is the identification, knowing the name, the date, the age, the type of the study, identical to your chest X-ray. When you're looking at the T and the type, there's various ways that we can do these. We can do an AP, either while the patient is lying down or when they're against the wall. Typically our patients are going to be here. But we can also do it a few other ways, and we can have this type of X-ray here where we can see air as it's going up to the top of the abdomen. So that's one way to orient it. And then here's another way to orient the abdomen as well for various pathophysiologies. For the most part, you are going to be seeing about 99% of these and maybe 1% of that. Okay, so technical factors. Good coverage is one of them. You want to make certain that you have the entire abdomen on there. You don't want to be taking shortcuts, so making certain that you can see the end of the pelvis as well as a few ribs to make certain that you get that epigastric area. Adequate penetration as well. Can you see intervertebral spaces? And you also want to know what view that you're dealing with. Okay? So as you can see here, this is a normal abdominal X-ray, and there's a few things that you can look at. Can you notice these lines right here? Okay, so these are muscles, psoas muscles here, so that's normal. You can see odd bits of dark air through here. Those are gas patterns. And typically what you want to find is you want to see gas in the rectum down here, and you should see gas interspersed. And you can see here that there is a nice gas contour here. You can see a gas contour. You see gas kind of throughout. And it's a little bit different than the chest X-ray because it's not, these findings are a little bit more subtle, and we'll go over those in detail. But there's sometimes you can see retroperitoneal structures, muscular outlines, and you're looking at gas patterns. And so we'll look at a number of gas patterns here. So as far as the IT free abdo, the free is going to be free fluid. And when you're talking about free fluid, this is one of the reasons why it's very difficult to detect clinically or even on chest or on abdominal X-ray unless there's a lot of fluid, because our fluid will go to its most dependent areas. And so if our patient is lying down, for example, it's going to be at the base of the abdomen, and your abdominal cavity is quite big. And by the time you feel it clinically or able to see it radiographically, there's going to be a lot of fluid there. Conversely, when you sit up, it's going to go to the dependent areas. Now I drew these diagrams here because it's not like the fluid just floats around like that. There are certain gutters called pericolic gutters that kind of uniformly cause the fluid to shift in certain predictable manners. But really, the reality is that it's very difficult to pick up clinically, and radiographically you'll need a lot of fluid to be able to see it. Ascites or blood are the same color, the same density on the radiograph, and I do have some examples here. So clinically, as I mentioned, you're going to be detecting fluid by percussion. And if the patient is lying flat, you can imagine that it's going to be very difficult to pick up because it's going to be very much to the base of the patient. But if they're lying on their side, for example, we might be able to appreciate a transition zone between where the fluid is and where there isn't fluid. But again, understanding that you need to have a lot of fluid there in order to feel a difference as far as percussion is concerned. And in kids, a lot of the times this is very difficult. I just demonstrate this to demonstrate a point that it's difficult to pick up clinically, and I wouldn't expect you to. So IT-free air, so air. Normal gas patterns are variable depending on what you've eaten, depending on transit time, depending on where the air hangs out. So again, this is a normal stomach, and we can see a gas pattern. If you look at this about 20-30 minutes later, the gas pattern is going to be a little bit different. The stomach typically crosses midline, and it's going to be right underneath the diaphragm. If you look at gas patterns here, so here's your stomach, as I said, right below the diaphragm, usually crosses midline, and you're going to see gas patterns throughout the abdomen, and this is what you expect, including typically air in the abdomen. Again, if you x-ray this patient the next day, the gas patterns are going to be a little bit different. The stomach for older kids are going to have nice defined musculature that you can see here if you're not sure if it's a stomach or not. And then knowing where the anatomy is, your colon is going to be your picture frame. It's going to be on both sides, and you're going to have a transverse here, and that's one way of recognizing if it's colon or not. There's other ways, but that's largely one way to orient yourself. Your bowel walls, trying to tell the difference between your large and your small colon. When you're looking at bowel patterns in your colon, you can see that these bowel patterns here are quite a bit different than your small patterns here. And it has to do with how the mucose folds. I don't expect you to know that difference, but just recognize that sometimes your colon has more of a train or a tire track mark, where your small colon has slightly different markings. But again, your colon, your descending colon, your ascending colon, and then it picture frames your abdomen. Bones, again, we talk about density, that's fairly straightforward. Sometimes you can have calcifications in your kidneys, but those are uncommon in kids, so I'm not going to go, sorry, I meant to sneeze there, in a whole bunch of details there. Again, more bone anatomy here, and in the neonates and the younger kids, a little bit more difficulty to determine because these points haven't calcified yet. Recognizing your organs, so this is right upper quadrant here, for example, underneath the ribs right here, corresponds very nice with the liver that ought to be there. The lung bases that we feel very comfortable with on chest x-rays are going to demarcate lung with liver, so that's fairly straightforward. You have your psoas, for example, your psoas muscles, and sometimes you can see nice clear delineations this way. And then you have another muscle, your iliacus, that is sometimes more difficult to see. But I bring this out because a lot of people look at that and think it's pathology, where it's really the psoas muscle. Kidneys sometimes are difficult to appreciate. They're on the outside of the psoas muscle. They have a density to them that's consistent of an organ, and you can kind of work that out that there is a kidney, and that corresponds with the kidney location. So again, being able to look at these x-rays and be able to say, hey, that ought to be there. Spleen is sometimes a little bit more difficult to pick up, but this demarcates it really nice as far as the kidney boundary and the spleen boundary is concerned. Bladder, sometimes difficult to see, sometimes not, depending on how full it is. And that's really it. What I would do is, all I wanted to do is to introduce to you what is normal and get comfortable with it. And again, when you're on service or when you're here, let's pull up x-rays and let's look at them. Okay, so what is an acute abdomen? Acute abdomen is something where this is an emergency. You either have significant, severe abdominal pain, and oftentimes it's accompanied with a focus involving the abdomen. The idea about transport is to identify if there's any life-threatening conditions, and a lot of the times this can be determined over phone to try to relieve the pain and to see what perhaps is causing this. So your goals are a little bit different because your acute abdomen, the question is, does it need an operation or not? You can't operate, I can't operate. If it does need an operation, they need to come here. If it doesn't need an operation, you can help control the pain in order to figure out if they do need an operation. So really, your goals are to get here as quickly as possible. Abdominal pain is very, very common. Again, if you go to the emergency department, almost 10% of the patients that are presenting there have stomach complaints. And the interesting thing is it's not only the abdomen, and most times in the kids it's not at the abdomen. It could be a UTI, it can even be an otitis media. It could be stress, for example. It could be an abdominal migraine. There are so many things here that can cause abdominal pain that doesn't require surgery. And really, our job is to ensure that we don't miss any of these surgical cases. But the fact that the team has already gone in to pick up this kid, somebody has deemed this kid to be sick enough to be evaluated, so this isn't really your call. Your call is to stabilize, to pain control, to bring him here, to get a surgeon to put the hand on the belly and say, yep, they need to go to the OR or not. So your roles and responsibilities aren't great. So based on age, I went over a number of things to think about, things that you see on the newborns. I'm not going to list them, they're there. But just to kind of get your thoughts rolling on what this possibly can be. It's not your role to discern, is it a mecal diverticulitis or a pancreatitis? That's not your role. But what are the danger signs? And what are the signs when you phone medical control or and say, listen, this kid is sick, a surgeon needs to be in the ER when we arrive. So if they look sick and obvious pain, a lot of these other ones, stomach migraines, UTI, this or that, yeah, they're not feeling well, but when you go in the room, the first thing you don't think about is, wow, they look sick. These kids with acute abdomen, they look sick. Sometimes their pain is increasing to the point where it's incredibly difficult to get a handle despite really seeing any other clinical signs. So that's really concerning, is increasing abdominal pain out of the realm of normal, obviously. If they have bile stain vomit, yeah, that's really concerning with the bowel obstruction. That means that the poo can't go down, and therefore it's going to go back. If they are really rigid, or if you press on their stomach and they're absolutely going off the wall, that is a really, really good sign as well. And so what I like to do is I like to distract the kids and press on their butt, on their stomach and see. If you can distract them and they're not bouncing off the wall, I know there's something else going on. But if I'm distracting them and I'm doing this and like, ah, don't do that, then I know, hey, I've distracted them, there's something going on here that's a little bit more sinister. If their abdomen looks like they got a watermelon, of course that's not a good sign. If there's acute blood loss, if they come to the emergency and their hemoglobin is 55 and they're complaining about abdomen pain, yeah, that's a big concern. Trauma is very easy, and hemodynamic instability. So really, I think you probably have the most experience with abdominal pain. You'll see a whole bunch of them. Okay, yeah, not to worry. But when these kids come in, these are the ones you can't miss. Surgical abdomen are some things here. Again, you don't have to be able to diagnose it because that's not your role. But these are the things that need emergent surgery. A volvulus means that basically you have a bowel that's a culvert and it flipped and it caused a folding on one another. A hernia, for example, a lot of kids have hernias, but what if the bowel went through that hernia and now it's squeezing? That's called an incarcerated hernia. Intussusception is, like I said, your bowel is a culvert and sometimes it folds in on itself. So it's like this and it folds in on itself and you can't reduce it. That's a problem. Malrotation is a problem as well. Sometimes these are diagnosed as neonates. An acute API may need surgery, but now we're trending to giving really aggressive antibiotics. So these are kind of the things to think in the back of your mind. What absolutely needs surgery?
Are we going to be taught to reduce hernias?
No.
What about torsion?
No.
Okay.
No. Testicular torsion? No.
No, I'm thinking because of the time.
I know.
Who are we going to practice on? Because it's so time
I understand your point. Typically, if we get a story like that, we will talk to the center, and there's really not much to it. They will try to do it,
Okay.
and if they're nowhere Manitoba and you don't get there for 3 hours, you've already lost it anyways. So, transport management. So really, the big thing is ABCs, like we always do, or CAB. And the thing for you to decide, is this an abdominal pain that needs surgery or doesn't need surgery? The one that doesn't need surgery, we can basically monitor, we can examine, and then we make a decision, does this kid need to come to HSC or not? Most importantly is the ones that are sick. And again, in a transport environment, what I would do is I would err on the side of caution of them being sick. Are they hemodynamically unstable? Is there blood loss? Is there pain in out of keeping for what you see? Do they have clinical signs of rebound tenderness, etc., etc.? Are they markedly distended? If that's the case, then what do we have to do? We have to establish an IV, monitor their vitals, give them fluid boluses as necessary, and analgesia, very, very important.
Would we ever be somewhere for this side of the?
No, but you know how it is sometimes. You get a
Yeah.
call, right? And,
Yeah.
and you go in there and either they're much, much sicker or better than billed. But yeah, we would never be called for this. This would be a perimeter kind of transport.
Okay.
But sometimes you get called for a kid
That looks,
that's
they
like that
say is
and
like
is like
that,
that.
but is like,
Yeah.
They look like
And
that.
vice
They pass
versa.
gas and then they end up looking like that.
Yeah.
Yeah.
So for the most part, that's where your roles and responsibility ends. They may have already done an abdominal X-ray, and hopefully we'll give you technology in your hand in order for you to forward that X-ray to us. But really, this is where your role ends. Okay?
And does medical control report to, like if we were coming through Emerge, would you report to Emerge or would we?
Yeah. So with all of these, the way our triage works is that everything goes through Emerge first. If they believe that you guys are required, it will go through us. And then if you have a kid, let's say that this kid has to go through Emerge because this kid needs to be seen by a surgeon, then I would phone Emerge and I'd say, remember that kid that we talked about 4 hours ago? It's going to come to Emerge. These are the reasons why surgery needs to be consulted. And then the kid might come up to us anyways, but we will be in dialogue with emergency with that kid.
Okay.
And there's nothing there about NG placement and decompress.
Yeah, so
That's
that
also-
goes a little bit later,
Okay.
I believe. So NG placement is absolutely part of it. NPO and sorry.
It does say.
Yes,
it's
yeah,
there.
yeah.
At the bottom.
Oh, but in some cases though, in evidence of an obstruction, but not in all cases. If they have an upper GI bleed, for example, the last thing I think you want to do is put an NG tube down.
Okay.
So that's not uniformly, but yes. So again, initial assessment, CAB, ABCs. Further assessment, very important, this is where you have that OPQRST history, onset quality, OP quality, R radiation, S severity, T timing, yeah, something like that. Associated symptoms, these are the type of kids that getting a reasonable history is important because that will help us get the information and is surgery necessary, perhaps what is going on in that abdomen. For any woman or girl that is menstruating, gynecology history is important because we could be dealing with a pregnancy, we can be dealing with several gynecologic, what the heck is the word I'm looking for? Ectopic pregnancy. Any girl who's menstruating, get a gynecologic history on her as well.
Our cutoff is 12. Always.
Always 12?
Always.
Clinical exam, again, do you hear bowel signs? How big is the abdomen? When you press down on the abdomen, what is that patient doing? For non-abdominal, because this is important because a lot of the abdominal pain isn't coming from the abdomen, a really bad lower lobe pneumonia, for example, can present as abdominal pain. So is there a pneumonia? Typically that will present though with fever, tachycardia, tachypnea. Is there flank tenderness on the back, for example? Are we dealing with the renal physiology? Pelvic and scrotal, like the torsion, testicular torsion. Jaundice associated with hepatitis and any sort of liver disease. Bowel obstruction. So most common, these are kids that have pain that comes and goes. That's colic. It comes and goes, comes and goes. When the pain comes, oftentimes there's vomiting and they don't want to eat. They're not hungry. So you can imagine if I went into your stomach or into your guts and I just clasped part of your bowels and clasped it up and wouldn't allow anything to go through, what's going to happen? Anything proximal to that is going to get bigger. So that's why you get this distension. This is why it's tender. You can imagine whatever is suffocating that bowel is causing tenderness. You can sometimes see peristalsis as the proximal bowel is trying to go through that obstruction. It's moving, it's moving. That's very early on. And because of that, sometimes you hear high-pitched bowel sounds. But of course, this ends as the bowel starts to give up, and those are later signs. So what can cause it? When we look at malrotation, there are some babies where as they were developing their gastric tract, it didn't rotate on the axis that it was supposed to. And this dotted line is retroperitoneal. So after the C-sweep, it goes retroperitoneal and then it comes out again. So this is a normal abdomen. And sometimes what happens with the malrotation is that nothing went retroperitoneal and the displacement is a little off. And consequently, what happens with this is there's something called Ladd's band. He was a surgeon, and these Ladd's bands helps obstruct the stomach so that it can't empty. So malrotation is quite common. How will this present? Well, you're going to have massive abdominal distension from the stomach. You're not going to hear bowel sounds distal to that. Most of the signs are going to be proximal to that. And you're going to have vomiting, vomiting, vomiting. So malrotation is quite common. Volvulus is another type, and this can happen really anywhere along the intestinal tract. And this is where you have guts that spin on top of or spin around and they twist. And again, here, this is the problem. And again, your symptoms will come anything proximal to that. So depending on where the volvulus is, that's going to be the obstruction, anything proximal to it. Now the danger to this, you can imagine, is as this is twisted, this is not getting blood supply, and this is getting darker, more and more ischemic, and eventually it becomes necrotic. So volvulus. Adhesions, what we see commonly in our surgical patients. Anytime you go in the belly, you get a massive kind of SIRS response, a healing response. You close the belly down, and adhesions form. And adhesions are a problem when they can cause an obstruction like this. And again, the problem with the obstruction is proximal because food can't empty, as well as the blood supply to this part gets compromised, and this can get necrotic as well. So again, the symptoms of the obstruction are proximal to that. So what do you see on X-ray? So when you look at the X-ray, you'll say, oh wow, look at that, we've got gas patterns. But you notice that every single gas pattern has a straight line underneath there. And that is called an air fluid level. And this basically tells us that we have an obstruction. There's no way that I think I mentioned this before, a straight line is never physiologic in any sort of medicine picture, and we have a straight line here. Gas in the bowel should never have a straight line. It should be all over the place. It should be a little bit here, a little bit there, but you should never have a straight line. And that's what we have here. We have what's called an air fluid level, where we have air above, and you can imagine that the bowel comes down here, but half of the bowel is filled with fluid. So we have an air fluid level indicative of a leak. If you can notice here, this is small bowel dilatation. And you notice that this whole X-ray here has small bowel, and you can see it. You can follow your finger through it. Again, this is abnormal. A normal gas pattern is a little gas here, a little gas there, a little gas here, a little gas here. Well, you have small bowel galore. And how do I tell it's small bowel? Well, I look at the Viva convenantes, I believe they're called, the mucosa folding. A. B, it's in the middle of the belly, and if it was large intestine, it would be picture frame. So this is definitely small bowel. But you notice that there's gas all over the place. Again, abnormal, because a normal gas pattern, again, little here, a little there, little there. So why is the small bowel dilated? Well, it's obviously obstructed somewhere, and it's probably obstructed very, very distal, because almost the whole small bowel is lit on fire here. Okay? So basic plumbing. How about large bowel? Again, if you look at the difference between that with that, we have now a picture frame. You can imagine ascending colon, transverse colon, descending colon, massive, massive, massive. Why? Well, you should never see a gas pattern like that. It's going to be large bowel. And you can see, well, where is the level? Well, we're almost at the level of the rectum here. So it is a very, very distal large bowel obstruction. Okay? So again, you got back up, to where the obstruction is, and it's obviously very, very distal in the colon. So those are obstructions. Any questions about obstruction? Again, people don't like to feed, they have pain, they're vomiting, and on X-ray, it's fairly easy. Air fluid levels, this is always abnormal, and this amount of gas and this pattern is always abnormal as well.